Hello, welcome. This is the 2026 NLA Annual Sessions in Chicago, and I'm your host, Dr. Peter H. Jones, and we're here doing an NLA podcast today. And I'm very fortunate to have an incredible lipid expert with me, as well as a great friend for many decades, and I'm not going to tell you exactly how many, but many. And I'm honored to be able to sit here and have a chat and a conversation about an important topic today. So my co-discussant today is Dr. Alan Brown, who's a past president of the National Lipid Association and a master of the NLA. And Alan, why don't you tell everybody what you do every day now?
Okay, that's probably not very exciting, but I retired from clinical practice about 8 months ago, and I am still a national coordinator for a couple of large clinical trials, mentoring some fellows who are getting ready to take the lipid boards. And I'm also doing some administrative work. So I function as a medical director for one of our health system hospitals, helping cardiology, and believe it or not, OB-GYN with strategic planning and growth strategies.
Oh, that's fantastic. Well, don't give up, keep working hard, and that's fantastic. Our discussion today is actually going to be about statin intolerance, and what I think every person who's done preventive cardiology and tried to treat patients to prevent cardiovascular disease has had a patient who said they can't take a statin. And, we used to call them statin-associated side effects, and particularly statin-associated muscle symptoms, or SAMs. What I've noticed, however, is a subtle change in the new 2026 multi-society guidelines for the treatment of dyslipidemia. They don't call it statin-associated side effects. They call it statin-attributed side effects. Why the subtle change in that discussion? Do you have an idea?
Well, I don't know exactly, but I guess the question is attributed by whom? So I think the statin-associated side effects were a group of experts that took a look at, was there an association with statins and certain symptoms? But all of us who take care of patients know that patients attribute a lot of symptoms, a lot of goofy symptoms sometimes, to statins. And I don't mean to demean the fact that certain folks do have statin symptoms, and I'm one of them. So I early in my career, being a believer in the lipid hypothesis, had some samples of a branded statin back in the day in my sample cabinet, and I started taking them. And then over a period of years, suddenly I started to feel sick, like I'd come up to the stairs and say, I don't want to go up those stairs. And I was fatigued and achy, and I thought something's really wrong with me. And it wasn't until I was talking to a patient and explaining statin side effects that I realized, you idiot, it's those samples you're taking. Stop that and see if the symptoms went away. And I would say within a week, I felt 10 years younger. And since that time, I'm on a different statin and I tolerate it. But sometimes after 6 months or a year, I could start to get a little bit of Charlie horses or some muscle fatigue. I stop it for a week and then I can take it for another year. So that's a little different than people saying that, they're getting dementia and, their teeth itch when they're on statins.
I think the most common, in clinical practice is the musculoskeletal side effects that patients will say they have. It's not just, my muscles ache or I get cramps. It's that my hip hurts more, my neck hurts more. It's like, okay, and then they're attributing it to the statin. So is the most common statin-attributed side effect mostly muscle or musculoskeletal related?
I think based on some of our surveys, it is still the most common. And unfortunately, there's a certain power of suggestion. And when people read the side effects, they can attribute many possibilities. As you know, when you do clinical trials, if someone has a runny nose, you have to include that as a potential side effect. So there's a litany of reported side effects with almost any drug. and patients tend to look for anything that worries them in the, description of drug side effects, and if they see it, they attribute it to the medication.
Yeah, but there have been reports of. I actually had a patient that had it of significant muscle injury with CK elevations. You might call it rhabdomyolysis, and my patient was a drug-drug interaction with taking a high-intensity statin. Then they got put on a drug that had a specific drug-drug interaction, and they ended up having rhabdomyolysis. And I think, back in the day we were told, oh yeah, before you put them on a statin, check the CK levels and do all these things. So it was a lot of focus on, the muscle is the primary statin-attributed side effect you're going to have. And of course, social media keeps that up and everything, watch out for those. Well, I mean, all of us will occasionally have some muscle problems here and there, and attributing it to statins tends to be something we have to deal with in our high-risk patients as to whether it's a statin-related problem or not. But, the other thing I think is fairly common, and again, you see it again in social media and postings, is cognition or mental fog or cognition issues. Do you find that to be a statin-attributed side effect?
Well, patients attribute it for sure. And I think what I explain to patients is that, first of all, there's no signal for dementia. That they've done
Correct.
large observational trials, and as well as now there hasn't been a really good prospective randomized trial of people who are randomized for risk factors for dementia to statin versus no statin.
Right.
But all of the statin trials, the observational data that we have suggests that it's either neutral on dementia or possibly beneficial. In fact, there was a large group, I believe they were out of Korea, that recently published an analysis where those people who had LDLs less than 70 had a significant reduction in dementia compared to those who had higher LDLs. And even more interestingly, those who were on statins had the lowest risk of dementia. So I quote that to patients. I do think, however, there is a rare individual who has trouble with calculations when they go on a statin. It doesn't show up in clinical trials. But there have been enough reports that even the FDA thought it was reasonable to look at it. And those very rare individuals will tell you, I had a physicist who told me this, that they had trouble balancing their checkbook when they were on the statins. And that syndrome may be real. Maybe they have some minor brain mutation that predisposes them to statin-induced calculation problems. That goes away when you stop it. There's no dementia there.
Right.
Within 2 weeks, it goes away based on the reports that we do have. And I believe that happens, but I think it's really rare. True brain fog from statins, really serious cognitive issues from statins, I think it doesn't happen. In fact, I know I told you this story once before, that I had a patient who told me he was going to sue the pharmaceutical company because when he started taking statins, it changed his personality, and that led him to a divorce. And I had to tell him, look, I've known you for years. You were a jerk before you were on the statin. You're still a jerk. It had nothing to do with
the statin.
He didn't take that too kindly. I don't think he ever filed the lawsuit.
I think that's funny. Well, they did the Samson trial with patients who had what were called muscle-associated symptoms with taking statins. And of course, that brought up the idea of the nocebo effect. All the patients who had demonstrable muscle symptoms were all given 3 bottles of pills, and 1 bottle was placebo, 1 bottle was the statin, and 1 bottle was empty. And the question was, when they took those pills for bottles per month, what happened? And nobody's symptoms changed. None got better, particularly when they were taking a 0 pill. So they sort of said, this is, the symptoms are more nocebo. If you think it's going to happen, it's going to happen. And if you're taking a pill, regardless of what it is, it's going to happen. So
that was an interesting trial, and I think we know that about 15% of patients will have side effects on placebo. Right. So that's just some weird part of humanity. But the facts are, no matter what we as providers think about it, whether the fact that their teeth itch, we in our mind know that it's probably not related to the statin. To the patient, it's a real side effect, just as placebo-induced side effects are, and they're not going to take
They're not going to take the pill.
So I think my first approach is, okay, this patient is not going to take this particular pill because they believe that's what's causing the side effects. And one, I think, myth is that if you have trouble with one statin, you're going to have trouble with all of them. And we know that's not true from prior studies. You could switch people. Sometimes you can even stop and reintroduce it. But I would say that, you just agree with the patient. Okay, for whatever reason, your side effect's weird, but you can't take it. So let's move on to another alternative approach. And I think you keep the patient that way. If you tell them it's all in your head, which I know you don't do, and you try and force them to go back on the medication, likely they won't come back and see you.
Yeah, in the new 2026 guidelines, they have a fairly nice section in the guidelines how to deal with statin intolerance. And of course, because of the data supporting statins, they would like patients to be on them. Most of them are generic and don't cost very much. And they teach us what to try to do. Okay, stop a statin. If they get better, switch to a different statin. Certainly, whatever dose you took, try a lower dose, and even maybe doing alternate day treatments. I mean, do you try those things with patients?
Yeah, so there's many strategies. The first thing I do is say, one way we can tell if the statin is what's causing your problem, especially in a patient with atherosclerosis, where I really feel strongly they have to be on therapy, is let's stop it completely and give it 2 weeks. And if you feel like a new person in 2 weeks, it very well may have been related, particularly muscle side effects. But if you're not sure you're a little bit better, then I would question whether it's really related to the statin. So let's start with that and let me know. If they feel remarkably better or they feel that they just don't want to be on that medication, then as we mentioned, one option is to switch statins. And, one of the things that has always bothered me a little bit is the focus on high-dose statins.
Yeah.
So this is sacrilege here, I know, but most of us who are lipidologists know it's the LDL stupid. It's not the dose of the statin, right? And you can currently give very low-dose statin with a second agent, ezetimibe or bempedoic acid, and get the LDL down. And,
exactly.
People say, well, you only get 17 to 20% with ezetimibe or bempedoic acid. But every time you double a statin, you only get an additional 6%, right? So that's like 3 doublings of the statin. So you can keep the statin dose low, and that's particularly helpful in insulin-resistant patients or patients that have a perception of side effects, and say, look, we can give you an additional therapy that's highly unlikely to cause side effects and get your numbers where we need to go without being on a high dose. So that's one approach. Obviously, you can gradually up-titrate another statin.
Correct.
Psychologically, sometimes using something like pitavastatin or pitavastatin at 2 milligrams, you tell them, I'm just going to give you a 2 milligram pill, and they will accept that, and they seem to do.
I've had that happen when they said, well, we've tried the 10, we've tried a 5, how about a 2?
Yeah.
And but you still get the same lowering of LDL than you do at the 5 and 10 milligrams of other statins, and so sometimes
even
more.
The 20, yeah.
Yeah.
And then if you add ezetimibe to that, and then the other thing that I know you know this, but a lot of times you can start out with twice a week statins on the longer acting ones. So rosuvastatin, atorvastatin, and pitavastatin, and give it twice a week even. And I know there have been several publications of every other day, but really the numbers look pretty good twice a week. And then you tell them, take a second agent, ezetimibe, bempedoic acid, but take that every day.
Right.
And then you can get really pretty surprising LDL lowering. I don't know if you've had the same experience.
I mean, I think that's true. Everybody's different in their response. There's always a waterfall plot in everybody's response, but sometimes you're very surprised at what you get with the doses that you do in some of these patients that you're.
And if that doesn't work, obviously you can get a PCSK9 inhibitor. So if it's a patient with coronary disease or FH, and they can't tolerate more than 2 statins, it's usually pretty easy to get them approved for a PCSK9.
Yeah, and I think that's what they say in the in this section in the guidelines on statin-attributed side effects is if you try those steps in high-risk patients that need LDL lowering, what do you do next? And you have the outcomes proven drugs that are available to you, and that's ezetimibe, PCSK9s, and bempedoic acid that you can add singly or in succession in order to achieve your LDL goal. And I think the reason they wanted to spend more time with that, I think, in the guidelines is because now they've returned to goals. Now you have to check your LDL. It's not just find a statin that they can tolerate. It's, get to the LDL goal. And here are the drugs you do if you have trouble with getting an adequate statin dose. We actually do have an outcomes trial that was done specifically in statin intolerant patients, right? What was that? Clear outcomes?
Clear outcomes, yeah.
What a fascinating, what is that?
Fascinating approach to a trial. And I think if you look at when ezetimibe did their trial, they had to have a lot of patients for a lot of years, because when you're dropping LDLs 20%, you need to have, first of all, either extremely high risk patients or a lot of patients over a lot of years in order to be able to have enough events to show outcomes. So the Clear Outcomes trial with bempedoic acid was fascinating. They had patients who could only be on a very tiny dose of statin or no statin at all.
Right.
So they almost had a placebo-controlled trial with a similar LDL lowering of 17, 20 to roughly 20%. And they chose high-risk people who had established atherosclerosis, but also some high-risk primary prevention patients. But they had the patient sign a paper that, we have told you, understand that statins have been proven to reduce the event rate and maybe even save your life, but you absolutely refuse to take them. And they also had the providers say, the patient,
will not add statins.
Yeah, I've discussed this with the patient, but they absolutely won't take it. And so they had, in the past, I don't think the FDA was really thinking about statin intolerance, because how do you define that? And also because of all the nebulous things we talked about in terms of attributable symptoms.
Correct.
Earlier. So this was a very clever way of getting a group of patients and being able to randomize them with them actually refusing other statin therapy. And of course, as you know, it showed a significant reduction in events, even in the high-risk primary
prevention.
Yeah,
I think it actually beat what we would expect. I mean, for most patients, a 20% reduction in LDL for most people is not going to be equivalent to a 40 milligram per deciliter reduction, which is from the Cholesterol Treatment Trials Collaborative Group, would give you a 22% reduction. So absolute LDL lowering was not that much. I think it was half that. And so you'd expect, man, they might be lucky if they get 10% reduction in events. Is that enough to be statistically significant? Well, they actually beat that, and it was statistically significant.
Interestingly, the primary prevention group had a bigger reduction than the secondary, which is hard for me to understand. And that may just be a little bit of noise in the data, because usually the highest risk people get the most benefit. But yeah, at least it was a proof that this method of lowering LDL, a new method, ATP citrate lyase inhibitors, gave you a reduction in events. And we went through that same discussion with ezetimibe in the past. And one other thing I like about the new guidelines is they broadened the use of PCSK9 inhibitors.
They did.
We had the Vesalius data at the time of the publication, but apparently not when they closed the guideline, the guideline document. But I think all of us knew that it's the LDL stupid, as we said earlier, and use what you need to get the LDL to goal and what the patient can tolerate. Because, as my father used to always say, the most expensive drug is the one that doesn't work or that the patient doesn't take.
Yeah. Well, in the old days when we didn't have statins, we had treatment-associated side effects on a regular basis. Niacin, everybody flushed and they hated the drug. Bile acid sequestrants, everybody had a GI side effect. But you could get many patients to take those drugs even under the circumstances because they believed that they needed help with their LDL cholesterol. And I think in some cases, if you talk to the patients enough and try to explain what you're accomplishing with statins, for instance, you can get them to take some statin at some dose. But now that we've got goals, we need all the help we can get from additional proven LDL reducing therapies that patients will tolerate. And I do think that when patients search social media or listen to Google and Siri, that they don't end up finding that ezetimibe causes muscle problems, or bempedoic acid causes me to have brain fog, and PCSK9s don't cause problems either. So they go, oh. So again, the fact that they don't perceive any problem with the drugs, they're able to tolerate them better, and we're able to get patients to goal on those therapies.
We may have dug ourselves into a situation where in the future statins aren't the mainstay of therapy, because maybe perception, but also we have more and more potent agents with potentially less side effects. For example, insulin resistance.
Correct.
And this fixation on statins has been mainly based on outcome data, which I don't want to belittle. It's fantastic.
Oh, I know. There's a lot.
And cost. Now that they're free. I remember when lovastatin came out, as I'm sure you do, we had to do slit lamp eye exams on everybody every 6 months.
Cataracts, yeah.
And everyone was saying, boy, if you get the LDL too low, cholesterol's in every cell in the body. What's going to happen?
Yeah.
And we had a lot of fear about it. But it seemed like such a potent agent. And now we've got way better tools in our toolbox and lots of options, which is perfect for this group of patients that struggles. And
it is. And statins still, very effective statins are still inexpensive. I mean, I take a statin every day, and my 90-day supply is $2.99.
Yeah.
So you don't find too many medications as effective as that for that price.
Mine's free, actually.
Yeah,
but it's not really free because we all pay our premiums for
right. But my copay is $2.99 anyway. So it's good. Do you have any other comments about statin-attributed side effects that you want the audience to know?
No, I just think it's important to listen to the patient. One saying that I've always had, and that it probably drives people crazy because I say it so often, is how you influence people. And as a physician, you have to have influence with your patients or they won't do anything. And if you remember that the way you influence others has absolutely nothing to do with what they think about you or the science that you're discussing with them. It's how they feel about themselves that determines your influence when they're in your presence. So I think not belittling the patient and saying, that ringing in your ear is probably not from the statin. You can say that, but you have to say, but, everybody's different. We've seen all kinds of things in our career. Not everybody reads the textbook. Let's try a different strategy. There's a look of relief on the patient's face because they've been told maybe by several doctors, that's crazy. It's not from your statin. Just keep taking it. So I think taking the time to actually listen and then knowing that there are many other options. You don't have to shove something down the patient's throat. And now we have clinical trial data supporting other options and a wealth of different tools in our toolbox.
I absolutely agree. And I also think that many practitioners in primary care need to at least acknowledge that if their treatments like statins are being given by a specialist, that they don't sit there and go, oh, yeah, I believe all those statin-attributed side effects. Yeah, you need to stop it. No, please go back and talk to your prescriber again about what's going on and make sure you find the right treatment for you to prevent cardiovascular disease. I just don't want primary care physicians to buy into the statin-attributed side effects patients say, yeah, go ahead and stop it. You don't need it. So as long as that's the case, patients can still get the adequate treatment that they need to lower LDL and prevent cardiovascular disease.
I think that's such an important point. And whether it's the provider believing them or their neighbor reinforcing them, this is something we don't talk about enough, I think. If you look at our achievement of goals over the last 40 years, we haven't made a whole lot of headway in a population of getting their numbers to goal compared to 20 years ago, even though we have better and better medications that are more potent and better tolerated, as we talked about today. And when you mention that to a group of providers, they get very defensive. Well, wait a minute, I prescribe statins on everybody with a coronary event, or, it isn't me, it's somebody else. And I would just say, don't get defensive. It may not be you. It could have been that they went to fill the prescription and it cost too much, so they never filled it.
Correct.
You may have prescribed it and they just didn't fill it. It could have been that they filled it and they started, having GI problems, and their neighbor told them I had the same thing when I took that pill,
Right.
and they stopped it. So you don't know from that appointment to your 6-month or 1-year appointment. There are a whole number of reasons why patients may have not adhered to your therapy or may have not even started it, even though you did the right thing.
Right.
So I think we have to accept the fact that the solution to this is, number one, make darn sure as a provider that you don't miss people.
Correct.
And that means develop a system in your practice or with your healthcare system where you don't miss people. But number two, we're going to need to follow people over time and find out what are those points where we lose patients.
Right.
And it'll be above and beyond what providers do. We probably haven't spent enough focus on those issues.
I agree. Alan, it's been wonderful to spend time with you, my good friend. I appreciate it very much. And thank you all for listening.
Thank you, Peter. Pleasure as always.